What if a simple vaccine could prevent 1 in 8 deaths among young children in Africa? The answer may be closer than you think. Here is the paper itself. RTS S, also called Mosquirix, is a malaria vaccine delivered alongside routine childhood immunizations in a 4-dose schedule. Before this study, malaria remained a leading cause of death in sub-Saharan Africa. 2 vaccines, RTS S and R21, had been approved, yet evidence of their impact on overall child mortality was sparse. Mwapasa and colleagues asked whether introducing RTS S through national immunization programs would lower all-cause mortality in real-world settings, especially when vaccine uptake is not perfect. The investigators randomly assigned 158 health service clusters, about 4,000 births each, to either introduce RTS S immediately or wait. They followed children for 46 months, tracking deaths and hospital admissions. Mortality surveillance relied on a network of local reporters who alerted study staff to every child death, which was then verified with a verbal autopsy. Hospital data captured severe malaria, and vaccine uptake was measured by routine records and dedicated surveys. Here you can see the geographic spread of the 158 clusters, with green areas receiving the vaccine in 2019 and pink areas serving as the delayed implementation comparison. The timeline illustrates when each country introduced the vaccine in implementation clusters and when the comparison clusters began later, allowing a clear before and after contrast. The key finding: the mortality rate ratio was 0.87, meaning a 13% reduction in all-cause deaths among children eligible for 3 doses of RTS S. This forest plot presents the pooled estimate across the 3 countries, confirming that the vaccine introduction was associated with a statistically significant drop in mortality. By the end of the study, over 80% of children received the first dose, but less than 3/4 completed the 3-dose series, and fewer than half received the 4th dose, highlighting real-world delivery challenges. The results suggest that routine program delivery of RTS S can save lives even when coverage is not perfect, supporting rapid scale-up across malaria endemic regions. The authors note that, although clusters were randomized, the evaluation remains observational, and differences in other health programs could influence the findings. Also, the study did not dissect deaths by specific causes beyond injury exclusion. Future trials should aim for higher 4th dose coverage, integrate transmission models to predict broader effects, and follow children for longer periods to confirm durability of benefit. In practice, delivering at least 3 doses of RTS S to most children can cut deaths noticeably, and boosting the 4th dose may further enhance protection. Policymakers should fast-track RTS S in areas with intense malaria, use the established vaccine delivery system, and keep robust surveillance to track impact. The trial size, the extensive death reporting network, and the careful random allocation across Ghana, Kenya, and Malawi give confidence that the observed mortality reduction is real. These findings reinforce the role of vaccination as a core malaria control tool, validate WHO guidance, and argue for funding to strengthen vaccine logistics where resources are limited. A warm thank you to Victor Mwapasa, Kwaku Poku Asante, Paul Milligan, and all co-authors for this rigorous evaluation, and to the Lancet for bringing these vital results to the world. Stay tuned for more evidence on malaria vaccine impact, and consider how you can support efforts to protect children in high-risk regions.